bronchiolitis and respiratory syncytial virus. Symptoms: prodrome, 1 to 2 days of fever, rhinorrhea, milder cough. Apnea may occur early before full intensity of chest symptoms. Persistent, increased cough may later be productive. Rapid respirations. Skin color changes, rashes, rare. Poor feeding, lethargy. Signs: findings of rhinitis, occasionally otitis, conjunctivitis. Pharyngitis, hoarseness. Tachypnea with usually shallow respirations. Tachycardia, especially when hypoxemia present. Fever, usually milder later in course. Nasal flaring, retractions, and hyperinflation. Wheeze, increased expiratory phase, and rales and/or rhonchi. Palpable liver and/or spleen, secondary to hyperinflation. Cyanosis, note, poor correlation with hypoxemia. Vomiting, posttussive. Evidence for dehydration may be present, secondary to poor oral intake. Investigations. Complete blood count, with differential, no specific findings. Pulse oximetry. Arterial blood gas if respiratory failure appears imminent, severe hypoxia. Raised or rising partial pressure of carbon dioxide. Rapid viral identification, usually a respiratory panel is available to include common seasonal respiratory pathogens by antigen detection. Viral culture, results delayed but may be useful to identify causative organism. Serologic diagnosis, paired samples needed, rarely indicated as clinical. Diagnosis is usually evident. Chest radiograph. Interstitial pneumonitis, the most typical finding, usually diffuse but may be segmental. Hyperaeration, also typical and may be the only finding. Peribronchial thickening, common but may not be related to the primary. Infection. Consolidation, occasional in hospitalized patients, usually is subsegmental. Complications. Otitis media, is most common, secondary, bacterial. Pneumonia, secondary, bacterial, occurs in 1% of hospitalized cases. Apnea. Respiratory failure. Cardiac failure, secondary to pulmonary disease or rarely myocarditis. Bronchiolitis obliterans, rare, usually associated with adenovirus-induced bronchiolitis/pneumonia. Differential diagnosis. Pneumonia, viral, bacterial, chlamydia. Pneumonitis, asthma, foreign body, cystic. Fibrosis, and pertussis. Gastroesophageal reflux. The diagnosis is evident when, during an epidemic period, an infant presents with tachypnea, diffuse wheeze, and hyperinflation, radiograph, after a febrile. Upper respiratory illness treatment. Lifestyle management. During the acute illness, routine health maintenance and respiratory care is provided at home or in hospital. Home management for mildly symptomatic patients is recommended. Adequate hydration should be assured. For significant wheeze or work of breathing, bronchodilator treatment, e.g., albuterol, may be tried. Reassess infant with increased respiratory distress and tachycardia. Oxygen saturation. Hospital care. Pharmacologic treatment. Corticosteroids, although controversial, a trial is reasonable for hospitalized patients in whom bronchodilator responsiveness is documented. Theophylline, not useful as a bronchodilator but may be helpful for management of apnea. Antibiotics, not indicated unless secondary bacterial infection detected. Ribavirin, antiviral, treatment, this is controversial because of concerns regarding cost, benefit, safety, and quite variable clinical efficacy conflicting. Chemical trials may be considered for patients who are at risk for severe or fatal infections, see other information, but no definitive indications have been established. Immunoprophylaxis, RSV intravenous immunoglobulin is approved for prevention of RSV disease children less than 2 years of age with bronchopulmonary dysplasia who have been oxygen dependent at least 6 months prior to oncoming RSV. Selected infants with premature to gestational age 32 weeks at birth, without BPD. Intravenous hydration, monitor intake and output, avoid excessive hydration. And aspiration. Consider use in severely immunodeficient patients, primary disorders such as severe combined immunodeficiency or severe HIV. RSV-IVIG is given at a dose of 750 mg per kilogram once per month beginning just before and monthly during the RSV season. Non-pharmacologic treatment. Infant showing inability to feed, severe respiratory distress, and/or hypoxemia should be hospitalized. See other information. Supplemental oxygen for saturation, titrate inspired oxygen to achieve 95% saturation. Note, nasal cannula may not effectively deliver oxygen if nasal passage not patent or patient mouth breaths. Bronchodilator trial. All hospitalized patients should receive a trial of an aerosolized agonist for potential relief of obstruction. Monitor oxygen saturation concurrently as hypoxemia may worsen in some patients. Improvement suggests continuation may be beneficial, and that airway hyperreactivity associated with asthma may be present. Careful monitoring of vital signs and clinical status as patient may worsen during inpatient stay. Use both electronic instruments and direct visual contact, include oximetry, and confirm progression to respiratory failure with arterial blood gas. Hospitalized patients should be isolated and may be cohort in the same room. Use gown, gloves, and careful hand washing. Additional control measures may be advisable beyond patient isolation. Measures. Consider laboratory screening for RSV infection in patients, cohorting. Medical staff, exclusion of infected staff from contact with high-risk patients, and limitations on visitation. Treatment aims. To adequately monitor until resolution. To maintain oxygenation. To assess reversibility of airway obstruction. To avoid complications of treatment. To identify high-risk patients. Prognosis. Acute severe obstructive symptoms usually resolve in 3 to 5 days, but cough and fatigue may last up to 14 days. Complete recovery expected for most patients. Patients with recurrent episodes of wheeze, obstruction, often found to have reactive airway disease. Chronic lung disease or other complications are rare and otherwise normal hosts.